My name is Ashley Holmes, and I am a family nurse practitioner student at Georgia College and State University. Today, I will be presenting a case study of a client recently diagnosed with Lewy body dementia. To protect this client's personal health information, I will be referring to him throughout this presentation as Mr. A.L. Mr. A.L. is a 66-year-old Caucasian male who first presented to the clinic on August the 8th of this year for complaints of memory issues and sleeping problems. He states, "My wife says I can't remember anything anymore. She's always getting on to me about sleeping too much. She won't quit nagging me about my sleep habit." He denies any recent illnesses or exposure to anyone sick. His wife states she first began noticing changes in his ability to recall about 5 years ago. Over the past year, his memory has progressively worsened. She states that she'll ask her husband to go to the grocery store for a jug of milk, and he'll return with nothing and can't remember what he was supposed to purchase. He might take 2 showers on a Sunday afternoon, 2 hours apart, because he forgot he already showered. His wife admits he might stay in the bed for 2 weeks and then have a period where he's alert and oriented and energetic for 5 days or so. She admits that he's acting out his dreams more. She says the other night he was standing at the window yelling at someone who was not there. She continues to apologize for not seeking help when she first noticed the changes in his cognition. She says they were both in denial. Mr. A.L.'s wife, who's here today, provides us with a detailed health history for her husband. He is not allergic to any medications, not allergic to latex, and he's not allergic to any food. In 2012, he was diagnosed with rapid eye movement sleep disorder, and he was also diagnosed with GERD at that time. In 2016, he was diagnosed with depression. He is up to date on his immunizations. He had a vasectomy in 1993, an umbilical hernia repair in 2006, and he's had several corticosteroid injections to his shoulders bilaterally from the years 2000 to 2016. Mr. A.L. states that he is unaware of his grandparents' medical history. His father had hypertension, and he is now deceased. He passed away at age 86 from a heart attack. His mother had type 2 diabetes. She's deceased, and she passed away at age 80 from pneumonia. His brother had hypertension, and he is now deceased. He passed away at age 56 from a motor vehicle accident. Mr. A.L.'s current medications consist of Lexapro, 20 milligrams, 1 tab daily for depression, and ibuprofen, 200 milligrams. He takes 2 tabs daily as needed for neck and back pain. He stopped taking ranitidine, 75 milligrams, twice daily in 2017. We'll now review Mr. A.L.'s psychosocial history. Mr. A.L. denies smoking, vaping, illicit drug use, and alcohol intake. He admits to drinking 1 Coke daily most days. He denies difficulty accessing medical care, has Blue Cross Blue Shield for secondary insurance and Medicare for primary. He receives Social Security income. He lives at home in a 2-bedroom, 1-story home with his wife of 21 years. His wife still works full-time. He has 2 daughters who frequently visit him. He retired from 30 years of welding and plumbing in 2016. Mr. A.L. graduated from high school, and he was born in Brunswick, Georgia in 1953. In his spare time, he enjoys woodworking. Mr. A.L. was asked to recall what he had eaten in the past 24 hours, and he could not remember what he had or had not eaten. His wife stepped in to answer. She stated he had nothing for breakfast or lunch, as sleeping through both of those meals. And for dinner, he had a large bowl of spaghetti with meatballs, a glass of milk, and one piece of garlic toast. His BMI today is 24.8. All right, we'll now review the subjective data, also known as the review of systems. For constitutional, the client complains of weight loss, fatigue, and weakness. He notes a weight loss of about 5 pounds in the past 6 months. Head, ears, eyes, nose, throat. He has upper dentures. He denies cardiovascular problems. He complains of occasional heartburn and constipation. For genitourinary erectile dysfunction. Musculoskeletal, he complains of weakness, shoulder pain, and lower back pain, and the shoulder pain is chronic. He does state that ibuprofen helps with pain. Neurologic, he has a history of rapid eye movement sleep disorder. The wife notes changes in his mood, attention, memory, judgment. She also notes increase in voluntary movements in his sleep and notes fluctuations in his memory, and states she believes he is more withdrawn than he has been in the past. He denies any endocrine problems, hematological problems, and problems in dealing with immunology or allergies. We'll now move on to the objective data, also known as our physical exam. For general, this is a pleasant 66-year-old, well-dressed, well-groomed Caucasian male who's in no acute distress, but appears anxious while sitting on the exam table. He does appear his age. He does not maintain eye contact throughout the interview and exam, and he does display some apathy. He turns to his wife for answers to most of the questions the nurse asks. He's alert and oriented to a person, place, and situation, but he does not know, he's unaware of the time. He can't verbalize what year it is. His speech is delayed and his voice is a little shaky. His vital signs are his height 71 inches, weight 178 pounds, BMI 24.8, respirations 18, O2 sat on room air is 98%, his oral temperature is 98.7 degrees Fahrenheit. His blood pressure is measured in his right arm and it's 118/72. Pulse is 74 and regular, and that was palpated in his right radial artery. His skin is within normal limits. His head exam reveals male pattern hair loss, stage 7, head completely bald with a classic horseshoe pattern. His eye exam revealed decreased blinking at 5 to 8 times per minute. Ears, nose, mouth, throat. Dentures were noted upon his exam, and they appear to be well fitting. They're only upper dentures. His neck exam revealed a shoulder shrug test of 4 out of 5, so there's some weakness there. Anterior and posterior chest and lungs were all within normal limits, and his breast exam was unremarkable as well. We'll continue with our physical exam findings. Cardiovascular was within normal limits. For the abdomen, there was a scar that was noted below the umbilicus due to the umbilical hernia repair he had. For extremities, we'll start off with the shoulder. Abnormal range of motion, pain noted with flexion, extension, adduction, abduction, and internal and external rotation. For the spine, there is also abnormal range of motion with pain noted with forward flexion, extension, lateral twisting, and bending. For the nervous system, mental status. We did a mini-cog test in the office, and his score was a 0, and I'll show you those results on the next slide. We also did a geriatric depression scale and his results were 13, and you will see those results in just a minute too. This is a photo of the mini-cog test that Mr. AL attempted to complete. The first portion of the test goes over recall, so he was asked to remember 3 words, which were banana, sunrise, and chair. And he was also asked to draw the face of a clock that read 20 minutes after 8 o'clock. And this is his drawing of the clock on the right, which did not read 8:20, appears to be more of 6:35, and he was not able to recall any of the objects that I asked him to recall. This is a photo of the geriatric depression scale that Mr. AL and I completed together in the office, and it shows that a score of greater than or equal to 10 points is almost always indicative of depression, and he scored 13. This slide is going to sum up our physical exam findings. Cranial nerves 1, 11, and 12 were not intact. For motor systems, they were decreased. His shoulder strength was 4 out of 5. For cerebellar function, the finger-to-nose test was jerky and inaccurate, as was his heel-to-shin test. He had a positive Romberg test for stance. For genitourinary and rectal exam were both within normal limits. Slide's going to go over my top list of differentials, and I'm leaning most toward Lewy body dementia. However, I want to rule out the depression as the cause of the memory issues, any sort of thyroid condition or brain tumor or other neurological condition. Unfortunately, the most recent labs I have on this client are more than 2 years old. They were drawn May of 2017, and they were within normal limits and included a CBC, a vitamin B12, a lipid panel, and a CMP. So for me to come to my conclusion, I need to get some fresh labs on this client, and I want them drawn tomorrow, and I want them to be fasting. And they will include a CMP, a CBC, vitamin B12 and folate, ferritin, total iron binding capacity, thyroid panel, an RPR, HIV test, and lipid panel, and a PSA. I would like for him to have an MRI of his brain with and without contrast at the hospital ASAP. I recommend that he restarts ranitidine, the 75 milligram tablets, twice daily for heartburn. It's an over-the-counter drug used for GERD. It belongs to a class of drugs called H2 blockers, and it works to lower the amount of his stomach acid. I also recommend changing the diet and trying not to go to bed until 2 hours after he's eaten. Also recommended lifting the head of the bed, elevating it. But I do realize this could be difficult due to his sleep disorder and due to his cognitive problems. I gave both he and his wife handouts on stretches that could help reduce his back pain, and discussed the need for following up with the orthopedist he saw in the past for his shoulder pain. We discussed the physical assessment findings, including the abnormal depression screening and mini-cog findings. I explained that I highly suspect dementia, particularly Lewy body, due to the client's history of REM, sleep disorder, and cognitive fluctuations. I explained that the other conditions could also cause memory loss, and that's why I want to do the labs to rule those particular conditions out, like a vitamin B12 deficiency. I obtained consent for HIV testing. We discussed the pros and cons of the MRI, including the cost. I did let them know that the MRI would not be definitive for Lewy body dementia, but it could help rule out other conditions and help us lean toward that diagnosis. I explained safety measures, including removing any weapons from the home due to the sleep disorder and his increase in enactments of his dreams. We discussed the pros of routines and a calendar to keep him oriented to time. Both the client and wife agreed to the above recommendations. I would like to see the client in 2 weeks after the test results. At that point, we will discuss further therapeutic options. Understanding was voiced by all discussed. It's been 2 weeks since the client was last seen in the clinic, and he is here with his wife for a follow-up. All of his lab results turned out fine, excluding his blood sugar, which was barely elevated. His read 101 on his report, and the high normal was 99. He thinks he may have had a Coke before he had his blood drawn, and the wife does confirm that, so that is why it's elevated. The MRI of the brain revealed moderate cortical volume loss, which can be consistent with memory disorder, and that's often seen with Lewy body dementia as well. We did an assessment toolkit for Lewy body disease today in the office, and the results were probable dementia with Lewy bodies. And here are the results from the Lewy body dementia kit that we did in the office today. So we now can confirm our suspicion of Lewy body dementia as a diagnosis. Second, Alzheimer's disease is the most common type of degenerative dementia. Degenerative means that the disease is progressive and it will gradually worsen. Alpha-synuclein, or abnormal protein found in the brain of clients with Lewy body dementia, affects chemicals in the brain. This causes problems with cognition and mood. There is no cure for this disease. However, there is medication to help slow the process and decrease the symptom. It's important to understand that the medication can fix one symptom while worsening another. I educated the client and wife on the importance of avoiding antipsychotic drugs, as the side effects can be irreversible for this group of individuals. I reiterated the importance of maintaining routines and keeping a familiar environment for the client. I also recommended investing in a whiteboard for messages to leave someplace nearby and noticeable for the client. That could help him stay up to date and could also help remind him. It would be a good tool for reminders. We discussed advanced directives, and we discussed support groups and respite care. We discussed safety measures, including fall hazards, and I recommended a trial of the Excellent patch. It's a 4.6 milligram 24-hour patch, and you apply one patch, leave on for 24 hours, remove, and apply a new patch in a new spot on the skin. Rivastigmine, also known as Exelon is the brand name, is a central acetylcholinesterase inhibitor. Acetylcholine is a neurotransmitter that plays an important role in cognition. It's released by motor neurons to trigger muscles. Clients with Lewy body dementia have lower levels of acetylcholine in the brain. Cholinesterase inhibitors work to decrease the breakdown of acetylcholine by blocking the action of cholinesterase, thereby improving cognition. Side effects include nausea, vomiting, weight loss, diarrhea, weakness, slowed heart rate, constriction of pupils, increased sweating, and mucus secretion in the lungs. It's recommended to titrate the dose. Every 4 weeks is tolerated, with the next dose being 9.5 milligrams and the max dose being, after that, 13.3 milligrams. Both the client and wife agreed to the above plan. I also discussed the prices of the patch versus the price of the pills. The pills end up being cheaper with this drug, but they have to be taken twice a day, and they need to be taken 90 minutes prior to a meal. The pills run anywhere from $1 to $5 each, and the patches run between $20 and $25 each. And both the wife and The client decided they wanted to go with a patch because the client states he does not like taking pills. So therefore, we're going to do the patches. We're going to do a trial of those, and I want to see the client back for a reassessment in 4 weeks. I encourage them to call with any questions or concerns, and they both voice understanding. Our final topic of conversation today is on the guidelines and research pertinent to this particular disease. The diagnosis of Lewy body dementia is based on progressive decline in cognition and also in executive function. The core clinical features include fluctuating cognition, recurrent visual hallucinations, and one or more features of Parkinsonism. Supportive features include sensitivity to antipsychotic medications, recurrent falls, episodes of unresponsiveness, hypersomnia, low blood pressure, urinary incontinence, apathy, depression, anxiety, and autonomic dysfunction. Indicative biomarkers include reduced dopamine by SPECT, abnormal PET scan, polysomnographic confirmation of REM, sleep without atonia. Supportive biomarkers include CT, MRI results showing intact medial temporal lobe structures, and abnormal results of an EEG. Probable Lewy body dementia can be proven or confirmed with 2 core clinical features or 1 core clinical feature and 1 suggestive feature. Management of this disease is pretty complex. Treatments based on symptoms, and then we have the cholinesterase inhibitors, which can reduce cognitive symptoms, can reduce apathy, reduce delusions, and hallucinations. And as stated on a previous slide, you definitely don't want to give these patients antipsychotics. They can have really bad reactions to them, and some that aren't reversible. We also need to remember the caregiver with these patients, making sure we refer them to respite care and just getting them the resources they need to, live a healthy life themselves. So the pricing for the diagnostic testing can be pretty expensive here. Like the video polysomnography is a sensitive test for the diagnosis of this particular disease, and the price ranges from $1,000 to $3,000, and sometimes insurance will cover it and sometimes they won't. So that would be something we definitely want to talk about before we, send our patient to have that done. Here are a list of my references, and thank you for your time today. Let me know if you have any questions.